which unfortunately you can hear it. Ooh, look at that viewer number. This stream was deleted on Facebook. Try creating a new stream. Or just remove this destination from the stream and re-add it. All right, well, you're going to fix that. Right? All right, welcome everybody. If you're tuning in live, it is Wednesday morning in February 11th, 2026. So we're going to talk about Medicare today. And if you're watching one of the recordings, it's still February 11th, 2026, the day we're doing it. So all the numbers we talk about are for 2026. If this is still out there in the world in 2027, remember the numbers will be different, but the concepts will still be the same. My name is Mark Bilgier with Bilgier Insurance, and we do a lot of things, but today we're going to talk about Medicare insurance and go through some of the basics. You often hear it listed as the ABCDs. Those are part of it, but what we try to focus on is helping you understand how your Medicare is going to be different than your neighbors. And so we suggest that although you can talk to your friends, neighbors, relatives, and do a little research, don't do anything they did just because they did it and they think it works for them. You need to talk to somebody, most likely, or what we recommend the most is a local broker, somebody familiar with your area and that writes for several different companies. If you work with a company-specific agent, they're going to steer you into their plans. That's all they're allowed to show you, so that's all they will show you. And no matter what, they'll convince you their plan is the best. But today we're not going to talk about any plans. We're just going to talk about how Medicare works, what you can expect from it, when you need to do things, when you have to do things, when you can do things, and hopefully put your mind at ease about how complicated it is. Because although it can seem complicated, it doesn't have to be if you work with the right person. So let's jump in to our slides. My name again is Mark Bilgier with Bilgier Insurance. And so the first thing we want to talk about is when you're eligible. You realize or notice that I underlined eligible. That's going to be a big deal. Because when am I eligible and when do I enroll are not always the same thing. But you're eligible the month you turn 65. So Medicare primarily is for people 65 years or older. There are a few people on it if they are fully disabled, but we're not going to focus on that today too much. So when you're first eligible, you have your initial enrollment period, your IEP, and that is a 7-month window. That is the 3 months before your birth month and the 3 months after. So 3 on each end, 1 in the middle. That adds up to 7. And when you enroll, it can start on the first of your birth month, or it always starts on the first of a month. Medicare never starts in the middle of a month. It always starts on the first of whatever month you start in. If you enroll in one of those 3 months before, it's still going to start on the first. So in this example, it's going to start in April. If you enroll in January, February, March, it's still going to start on April 1st. If you enroll after April 1st, it's going to start the next month on the 1st, so May 1st. If you enroll in May, June 1st, and that's how it works. So you can't start it early. You can enroll early before your birth month, but it won't actually start. If your birthday happens to fall on the first of the month, you get to start a month early. So it doesn't happen for a lot of people, but for every few people you run into, they actually get to start a month early. And there's a little comment, if you're getting Social Security Disability, SSDI, after you've had it for 24 months, in your 25th month, Medicare automatically kicks in. That's not most people. So most people, the month you turn 65, you have a 7-month window. Remember, that's when you're eligible for it, and that's your initial enrollment period. How do you enroll if you want to do it? Well, if you're collecting Social Security already, say you started at 62, 63, 64, and are taking your benefits early, well, then you don't have to do anything. You'll be automatically enrolled in Medicare when you turn 65. And that's very convenient. It'll start. And for your convenience, they'll start taking your Medicare Part B premium. Yes, there is a premium for Medicare. It is not free. We're going to talk about that. But Social Security will conveniently take that out for you before you even see your check. So if you're getting your Social Security retirement benefits and your benefit is currently $2,000, once you go on Medicare, it's going to be about $1,800. And that's just the way it is. And that's how it's going to work. If you're not collecting Social Security and you want to start your Medicare, say you're still working, but you want to drop employer benefits and go on Social Security, you just go on to ssa.gov and sign up for Medicare. That ssa.gov, that's very important. If you have not already created your ssa.gov account, that's the one takeaway that you should get from this whole discussion. Go create your Social Security account. It helps you when you want to apply for Social Security and when you want to apply for Medicare. And anytime you're not prepared and you start doing things in a rush, that's when things get hosed up. And either your Social Security or your Medicare may not come out the way you want it to be, or you'll be fighting and they'll need all kinds of documentation and you'll have to make appointments and it's a nightmare. If you do it early and just have it ready to go, chances are things will go smooth. They're pretty good, but they're not perfect. So here's the most often question I get. The question I get most often when I'm eligible, do I have to enroll in Medicare? And the answer is no. You have to have creditable insurance, creditable coverage once you're 65. And so what people are really asking me is, can I continue to work and use my employer benefits? Absolutely. Absolutely, you can. However, if once you turn 65, you're not working or you don't have employment benefits, you don't have benefits through a spouse, then you do have to enroll. If you don't have creditable insurance, so remember, there's a difference between having Medicare and creditable insurance. If you don't have insurance, then you are subject to a Part B penalty, which is 10% of the Part B premium for every year you delay it. The Part B premium goes up every year, and that penalty lasts for your entire life. It never goes away. And as Medicare increases, so does that penalty. That 10% comes off a bigger number. So the penalty increases and lasts forever. So you really don't want to do that. And you're subject to a Part D penalty, which is your drug prescriptions. So if you don't have your Part D coverage, that's going to be 1% for every month you don't have it. Once you're eligible, you have 63 days to enroll in Part D. For every month you don't enroll, they're going to charge you 1% of the average Part D cost. And that penalty lasts forever. So penalties are really avoidable. It's easy to avoid them. You just have to understand creditable insurance. You have to have some sort of insurance once you're 65, either through your employer, your union, your retirement plan, your spouse's plan, your spouse's employer, through Medicare, or that's about it. If you don't have one of those, then you're going to be subject to Part B and Part D penalties. They're easy to avoid. Don't get them. They last forever, and they'll eat away at all your retirement. We don't like it. So what if I want to continue working? What do I want to do? Well, you can continue your employer benefits if your employer has 20 or more employees. Why does that matter? Because insurance policies that cover 20 or more employees are considered creditable. Remember that word, creditable insurance, which means it's as good as or better than Medicare. And if they have less than 20, they don't consider it that way. All right. You'll hear people say a lot of enrollees enroll in Part A because it's free and it's a little extra hospital insurance, so you might as well just do it anyway. All right. So for most people, it is premium free. It's not free because you pay for it every month. When you see that FICA deduction coming out of your paycheck every 2 weeks or every month or how often you get paid, part of that is going to pay for Medicare Part A. So once you've worked 10 years, 40 quarters, now you have premium free, but it's not free. You just paid for it ahead of time. But that next bullet really has a lot to do. If you're with your retirement, your contributions to an HSA are dependent upon having a high deductible health plan. So if your employer plan is a high deductible plan and you're contributing to an HSA or your employer is contributing on your behalf, that's great. That's money you're going to use for future medical expenses or current medical expenses. But you get to put that in tax-free and use it tax-free for medical expenses. If, however, you start Part A, that is no longer a high deductible plan. You can no longer contribute to your HSA. So out there in the ether, you hear a bunch of people say, well, just get Part A anyway because it's free. That's not the recommendation that we normally give. First, we ask, are you contributing to a health savings account? And if you are, then let's talk about it. It may not be enough benefit to have that Part A if you still want to contribute. If you're done contributing or you don't contribute at all, then maybe it is. But just because you hear it out in the wild, as they say, doesn't mean it's a good thing. Once you leave the employer benefit plan, so you can work till you're 70, 68, 63, or I should say 63, 67, whatever it is, and you leave your employer benefit, now you're going to have a new enrollment period, right? It's not your initial one because that was back when you were 65. Now you're a little bit older and you need to enroll in Parts B and Part D. Part D, you have 63 days from when you leave the employer benefits to get into Part D. Part B, you have 8 months. And then that's when the penalties can start. They're going to start tracking them. You're not going to get a penalty the next day, but that's when the countdown starts. That 8 months, a lot of people may be on COBRA, but they may have COBRA offered for 12 months. COBRA does not count as creditable insurance. So people will think, oh, I'll just be on it. Or maybe your plan lets you stay on it longer. Yeah, it's a higher premium, but I like, our benefits, or I just don't want to go through the hassle. Well, after those 8 months, COBRA does not count as creditable insurance, and the countdown for penalties starts then. So talk to a broker who understands these rules and make sure you avoid those penalties. All right, the ABCs and Ds. This is where everybody gets bogged down. I try to make it a little simpler. If it feels, like I'm not dwelling on it, that's because you get lost in the minutia, and the minutia doesn't really matter. What we care about is who's paying the bills and are the bills being paid. So what is Part A? Part A, everything in Medicare has at least 2, if not 3 names. It's facility, hospital. I call it inpatient care when I'm talking with my clients because it means I'm an inpatient in a facility, right? Somebody else's building. So, but I'm an inpatient. The most common is your hospital. Part A, remember, is premium free, but it does have deductibles and copays. If you go in the hospital in 2026, day one, you're going to pay $1,736 for Part A. That's for being in the hospital building. Now that covers you for the first 60 days. Days 1 through 60, that takes care of your room and board. So that's not too bad if you're in there for any extended period of time. It's high for one day, but not terrible. However, if you're in more than 60 days, you can see you start having a daily copay, $439. If you're in for over 90 days, it jumps up to $868 per day. That's per day for each one of those. And so there's no limit on that, right? Other than multiplying that daily rate by all those days. So what's important about that is not so much the numbers, but that there is a gap and we need to find a way, because that could get expensive, right? And insurance is to protect ourselves from things becoming catastrophic. What's another building I could be in? I could be in someone's skilled nursing care, what a lot of us call rehab, right? You have a surgery, you're not able to put weight on it, but you don't really need to be in the acute hospital. So they send you to the rehab center for a week or 10 days so you can get up, get your strength before you go back home. Medicare Part A does a pretty good job on that. They actually pay the first 20 days for you. So you can see days 1 through 20, $0 copay. However, after that, it jumps up pretty quick, $217 a day, up to 100 days. After that, you're at 100%. You pay the full cost of being in that rehab center. So it's not a place to spend a lot of time. It's a place to get well enough so you can go home. Sometimes home health care can fall under Part A. And even though that's in your house, Part A will still cover it. And that's if it's prescribed as you're leaving the hospital. Typically is how that works. 2 to 3 days a week. This is where it gets confusing. Is Part A or Part B paying it? Doesn't really matter to you as long as one of them is paying it. Some people still end up in a hospice facility. There can be small charges for that. However, hospice comes down to most people want to do that at home, and there's no cost if you do it at home. Psychiatric care, if you're in a psychiatric hospital, is basically billed the same as your acute medical hospital. So Part A is when you're an inpatient, other than a few times some home health care might fall under it, but it's not worth worrying about when it does and when it doesn't. Part B, here's the easy way to remember it. Part B is the opposite of Part A, right? So now it's your physician, your medical, or your outpatient care. So now I go someplace, somebody does something, and I go home or I go wherever, right? So it's outpatient care. Or people do things to me at the hospital, like a doctor does something to me. That could fall under Part B. Part B does have a premium every month. The base rate in 2026 is $202.90 per month. So this is the amount that if you're getting your Social Security retirement benefits, they're going to deduct automatically. So your Social Security check, if you're already getting it, is going to go down this year by $202.90 to pay for your Medicare Part B when you start Medicare. Medicare Part B also has an annual deductible. $283 is the amount for 2026. These amounts go up every year. So for 2026, it's $283. That's really not too bad. That's quite a good annual deductible. I wish, all plans had a deductible like that. So then what happens? So I pay my monthly rate. I paid my first $283 deductible. Now Medicare becomes an 80-20 plan where Medicare pays 80% and leaves you 20% coinsurance, and there's no limit on that 20% coinsurance. So that's another gap that we need to try to help people fill down the road, because with no limit on that, that could get expensive pretty quick. That's where some of your catastrophic costs could come into play. So what's physician, medical, outpatient care include? Things like going to the doctor, going to a specialist, MRIs, CT scans. If you get outpatient surgery, go to the emergency room, have to call an ambulance, and then some limited outpatient drugs. So a few drugs will fall under Part B, and those are drugs where you have to go and someone else has to give it to you. That's typically how you can decide whether it's a Part B or Part D. If you can just give it to yourself, what we call self-administered, that's probably going to fall in Part D, and we're going to talk about that in a minute. If you have to go someplace and a nurse or a doctor or a technician has to give it to you in some way, that's typically going to be a Part B drug and fall under this plan, this 80-20. And we're going to talk about this in a minute. That $202 is based off your income from 2 years prior. Notice that I said that's the base rate. Some people pay more than that. Higher earners can actually pay more than that. And towards the end, we'll come back and touch on that again if Paris reminds me. Or we'll just do it now because I already have it in there. So here's the rates for 2026. And you can see if you're married filing joint and your adjusted gross income is $218,000 or less, you get to pay the Part B premium, the base rate, $202.90. And there's no IRMA or income-related monthly adjustment amount is what we're discussing on your drug plan. However, if you're a higher earner and your adjusted gross income was between $218,001 and $274,000, now you get bumped up to $284.10 a month for your Part B. Same Part B coverage, you just get to pay more. And they're going to add $14.50 to whatever your drug plan costs. So if up here it was $20, now it's going to be $34.50. And the higher you earn, the more it could go up to the highest level of almost $690. And this is per person. So if husband and wife are both on Medicare, that'd be $690 per person per month, plus an additional $91 onto each one of your drug plans. So it can get pretty expensive now. That's higher earners. So, they think it may work itself out, but it's never a good thing to get an IRMA. We always try to avoid it if we can, and there's ways we can work with it, but you need to work with somebody who can do that with you. Agents or at an 800 number or on a call center, they're not going to have any idea how to help you with that. All right, so for Part B, remember you have to have creditable coverage, as good as or better than Part B. COBRA is not considered creditable coverage. Remember, COBRA can last those 8 months, but after that, it's not going to count. You have 63 days to get into your Part D plan because we want to avoid those penalties. If you use the VA, their health coverage is not considered creditable. So you can't just say, well, I went to the VA for the first 5 years. I didn't want to pay that Medicare premium, but now I do. You'll get penalized for those first 5 years that you didn't have it. They do not count the VA as creditable health insurance. All right, so what is Part D? Part D is prescription drug plan. So if you're covered through your employer or your spouse's employer, just like Part B, you do not have to enroll in Part D. If you're covered for prescriptions through TRICARE or VA, you do not need to enroll in Part D. This part can get confusing for people. Remember, the VA health is not creditable. The VA drug does count, and you do not need to get a standalone drug plan if you can use the VA for your drugs. So there it is. It's creditable for drugs, not for healthcare. In 2026, the average price for a standalone drug plan is about $34.50. This average is pretty worthless because the plans are really either very inexpensive or very expensive. There's not that many right in the middle, just one or two, depending on where you live. Most of them are either very expensive or very inexpensive. So the average comes out in the middle, but it's not a great representation of what you're likely to pay. So how do we price drugs and what makes them cost so much or so little? Well, they're all listed in a tier and they're not all treated the same. They come into 5 different tiers most often. The first tier is always preferred generic drugs. These are the least expensive. These are the ones that a lot of us take every morning or every couple times a day. Statins, thyroid, blood pressure, things like that. Metformin, a lot of pre-diabetics are on metformin. Those things are tier 1 preferred generic drugs. They tend to be very inexpensive, if not zero, depending on your plan. Next is tier 2. This is going to be somewhat obvious. They're generics, but they're just not the preferred generics. So they're going to cost a little bit more, usually somewhere $5 to $10 in a plan. It's all specific to the plan, so I can't tell you exactly what they're going to cost. The next level where they start to get more expensive are preferred name brand drugs. So these are the name brand drugs that are preferred by the drug companies, and they're going to start getting expensive. If you see a drug advertised on TV, it's either a tier 3 or above. And then you have non-preferred branded drugs. Those are tier 4s. Those are going to cost even more. And then your specialty drugs, tier 5. And those are very, very expensive. And you will know if you're on a tier 5 drug because it's going to be something you really notice. You're going to notice 3, 4s, and 5s. 1s and 2s, most of us are used to. 3, 4s, and 5s, they can really add up on you kind of quick. If you see it on TV, it's at least a 3, could be a 4, could be a 5. So we're going to look at our Part D. We know our tiers. that affects our costs. But drug companies want to keep their costs down too. So how can they do that other than recommending different tiers? Well, they use what's called step therapy. If there's multiple drugs in a category, they're going to ask that the doctor put you on the least expensive of the drugs. Try that one first. If it doesn't work, then we may step you up to a more expensive one. It's very common. They'll do it as often as they want to, or as often as they can. You'll find the drug companies have a lot of flexibility. You may not, but they do. They'll limit quantities on certain drugs. It just depends on the prescription. Some drugs have opportunity for abuse. Those are going to be limited, of course. Other drugs are just kind of expensive, but they're only meant for short-term use. So they may not write 30, or they may not write 90 days. They may only write 30 days. And you think, well, what's the difference? Well, to them, they think maybe 30 and you're going to be done. You're not going to need 90, and they don't want to spend the money if 30 is going to do it. So that just depends on the specific drugs. Then they can have pre-authorization where the doctor writes a script for something, take it to the pharmacy, and they say, oh, it needs pre-authorization. The insurance company is going to go back to the doctor and kind of double check with them, make sure that it goes through their approval process before they're going to fulfill it. This happens quite often on, expensive drugs. However, you can get a formulary exception sometimes. So this is a little bit different. Every drug plan has a formulary that lists all the drugs that they covered. Now, they have to have a drug in every category, but they don't have to have every drug that's available in every category. So there's multiple drugs for the same conditions. And if their drug is not in your formulary, or if the drug the doctor writes is not in the formulary, the doctor can ask for an exception and see if the drug company will cover the one that he or she thinks you should be on. Well, first they're going to have to fill out a form, request it, and give them a reason why you can't take the one that is in the formulary. And then the drug company gets to decide whether they'll approve it or not. It's up to them. They can deny it. They can approve it. It does happen. They do go through sometimes. Sometimes they may not. It just depends on the drug company. But it can happen. So before you panic, always talk to your doctor and get information about a formulary exception. The best way to avoid that, however, is work with somebody that can show you how to use the government system and to check all your drugs against all the drug plans in your area, and you can find a plan that covers all your drugs. It's a very easy system. We're starting to help a lot of people understand the technology, so ask a broker if they can show you how to use it, and they'll be happy to do that for you. So remember, they can use step therapy, they can do quantity limits, they can get pre-authorization from the doctor and say yes or no, and they can get formulary exceptions sometimes where they swap out a drug. So what does it cost me to have my drug coverage? Well, remember I said that average price is about $34. That's really not that much help. How we do it is we show you how to check all your drugs in the system. You put them all in, it'll tell you, here's the least expensive plan. It's going to cost this much per month. Some are $0, some are $160. It just depends on your specific drugs, because the difference is the formularies, right? Who covers what drugs and at what level. So that's why we can't tell you that without going through the system. But we can tell you how the phases work. There's 3 phases in 2026. The first phase is the deductible phase. Now, if you want to feel like it gets complicated, this is where it does get complicated. There is a maximum deductible that the drug companies can charge in 2026, and that's $615. So of that $615, if the drug company wants to, they can charge less than that, and many of them do. Or they can charge no deductible, and many of them do for the cheaper drugs, the tier 1 and the tier 2 drugs. A lot of them waive the deductible. So if you just take, lisinopril, and that's the only drug you take, you may be able to go in the pharmacy and get it for $0 in January. If you take Eliquis, you go and you're going to start paying that $615 deductible first. You're going to pay the retail price till you hit that $615, and then you're going to start having a copay, whatever your plan is after that, $45 or 25% or whatever it is. But because that's a tier 3, right? Tier 3s and above, you're going to have some deductible. Tiers 1s and 2s, you probably won't. I don't know every plan all over the nation, but in Dallas-Fort Worth, they tend to be 0 on 1s and 2s, and then the deductible at some level kicks in on 3, 4s, and 5s. Once you hit your deductible, then you're just at copays or coinsurance, depending on your plan. If you're not familiar with the difference, a copay is a set amount of money. So your copay is $10 or $15, or coinsurance is a percentage. Your coinsurance is 15% of the retail price or 25% of the retail price. So it could be different based on the drug. So a copay is a set amount of money. Coinsurance is a percentage. And so the actual dollar amount could be different. But you pay that copay until your out-of-pocket reaches $2,100. If that happens any time during the calendar year, then all your copays go away and you've hit the catastrophic phase, and you don't pay any more copays for the rest of the calendar year. And it resets January 1st the next year. That goes up every year. Last year was $2,000. This year it's $2,100. It'll reset next January. Can't tell you what it will be, but it shouldn't be dramatically different, but it will most likely be higher. That $2,100 does not affect most people. Most people do not cap out at that. That's protection for the people on very expensive Part D drugs. It really helps those people, but most people don't hit it. So I'm not down on it totally, because I know it helps a lot of people, but it also causes a few other prices to go up. So it's one of those give and take things. But if you ever hit 2,100, then you're done for the rest of the year. You see our little note at the bottom. Brokers are not able to run your drugs anymore starting in 2026. But a lot of brokers and a lot of businesses like us, we're showing people how to use the tools that are available so that you can do them on your own. So we saw the gaps. Remember the Part A deductible, Part A copays, Part B copay, coinsurance, the 20%. Those things can become catastrophic. So there's two ways to cover those costs. One is either a Medicare supplement or a Medigap. You're going to hear people say both of these things. They are the exact same thing. Medigap and a Medicare supplement are the same thing. It's another policy that's offered by a private insurance company, and it has its own monthly premium. That amount, of course, depends on your age, your gender, where you live, those kinds of things. All right. It's accepted by all doctors that accept Medicare. So when you hear about networks and does my doctor take it or does my doctor not take it, it doesn't matter. On Medicare supplements and Medigaps, if they accept Medicare, they accept a Medicare supplement. What will it pay for me? It'll pay all the Part A charges, the deductible and the copays. Well, that's pretty good. It'll pay that 20% that Medicare Part B doesn't pay. So you still pay your $283 deductible, $283, which is very reasonable. And then when you have the 20% coinsurance, it's going to pay all that for you. There's two main plans in the market. There's more than two, but the two that most people are gonna choose are either Plan G or Plan N. Plan G may cost a little bit more than a Plan N. Plan G has no copays with it. Plan N could have copays when you go to the doctor or go to the emergency room. They're very reasonable. Just you need to work with a broker, have them show you both prices. Is it worth it? It just depends on your personal situation. That's where we go back to whatever your friend, neighbor, or relative did might be great for them. It may not be the best for you. So work with a broker that can walk you through all the different options. However, you see that a Medicare supplement does not cover your drug plan or does not cover your drugs. So you have to get another plan, a standalone drug plan that we talked about. They come from private insurance companies. They help cover the cost of Part D medications, which are self-administered. And the difference, again, if it's self-administered, it's going to be your Part D. If you have to go someplace, chemotherapy is a great example. If you have to go to an infusion center, that's going to be Part B, and that's going to be covered by your supplement. The other way people fill those gaps is with a Medicare Advantage plan. And just because it can be confusing, that is also called Part C. This is the part that I think confuses a lot of people. They think Part C is part of the government, like Part A and Part B. It is not. It's a private insurance plan offered by private insurance companies. Part C and Medicare Advantage are the exact same thing. Private insurance, Part C is not required. It will have copays and coinsurance built into it. It'll be in a network, either an HMO or a PPO. Most of them include your Part D. There's a few that don't, but they're for people who are using the VA primarily, because you need to have Part D coverage. And really the only people that don't have to have it are people that can use the VA. They have what we call a maximum out-of-pocket amount for the year. I feel this is one of the most valuable parts of an Advantage plan. This protects you from anything catastrophic. Here in the Dallas-Fort Worth area, the average is right around $4,000, give or take. That means if all of your copays and coinsurance ever add up to $4,000, we'll just use that general number, in the calendar year, just like that catastrophic phase in the drug plan, now all your copays and coinsurance go away for the rest of the year. That is tremendously valuable. That's what protects you from a catastrophic medical bills. All right. The other thing you'll see, and this is what they advertise a lot, and I caution you, focus on these things up here: the network, the max out of pocket, are your drugs covered, things like that. Focus on those before you get into the extra benefits. Dental, eyewear, hearing aids, fitness. You notice I put in eyewear because the way they're going to say it on TV is dental, vision, hearing, dental, vision, hearing. And it scares a lot of people because they think, oh, if I get glaucoma or macular degeneration or something like that, I don't have vision insurance. That's not true. That's medical insurance. A supplement covers that. And an Advantage plan covers it too, but it's under medical. These extra benefits are glasses and contacts, not disease in your eyes. So just be aware of that. And then some of them throw in a fitness, not all of them. Some of them throw in what they call over-the-counter benefits, which is money each quarter that you could get vitamins or Band-Aids or hand lotion, different things. They all have a different catalog. They all have different prices. They all offer a different amount. So again, work with a broker. They can explain all the Advantage plans in your area, and they can explain how Medicare supplement works, the cost between two, which is better for you. That is the main idea. What's going to be best for you as an individual? Just to review, your Part C combines your Part A, Part B, and Part D into one plan, eliminating some of the out-of-pocket. Well, what does it eliminate? It eliminates paying premiums. Most Advantage plans, many Advantage plans in bigger areas are zero premium. We don't want to say they're free because they have co-insurance and copays, but they're zero premium. Other parts that aren't as big, as not a big a metroplex, they could have premiums on their Advantage plans too, but they're still usually pretty reasonable. All Advantage plans are going to have set copays or coinsurance listed for the services. So if you go to a specialist, it'll tell you how much it is. If you have an MRI, your plan will tell you how much it is. If you need an ambulance, there's a fixed cost to that. If you go to the emergency room, there's a fixed cost for that. Your plan says what it is, and so that's what it will be. So every plan is different. Got to work with somebody who will walk you through the different plans and show you what's going to be best in your area. They're all going to have a network. Not all doctors take all plans. That's very common that, a doctor doesn't take one plan or another plan. If you have a whole lot of doctors, finding all of them in the same plan can be a challenge sometimes. So again, work with somebody that can help you figure all that out. They all have that maximum out of pocket. I think that's just about the most valuable part of an Advantage plan. They're all built off a 5-star system or rated on a 5-star system. 5 stars being the best, 1 being the worst. You'll never actually see a 1 because once they're below a 3, they get a lot of warnings, and then the CMS, Center for Medicaid and Medicare Services, makes them pull it from the market. So they do try to work to protect you. We basically work with 4s because most of the plans in our area can be a 4. There's a few 3.5s. 5s kind of come and go because it's really hard to get. In fact, they make a special enrollment period. If a company gets a 5-star rated plan, they give people an extra opportunity to enroll into it if they want, because that plan is doing a really good job, and the government wants them to have 5-star plans, but they do make it hard for them to get it. So if you see it, they're worth looking into. When you see the advertisements in the fall, October through December, those are primarily about Advantage plans. And I want to caution people who are new to Medicare. If you're new to Medicare, your enrollment plan is not in the fall, October through December 7th, October 15th through December 7th. That doesn't have anything to do with you. If you're new to Medicare, because you're turning 65, your enrollment period is based around your birthday. Now, if your birthday falls in October, well, some part of that's going to overlap. But that whole thing in the fall does not apply to you that first year, that first time you're enrolling in Medicare. So don't think just because you see it on TV a lot that it necessarily applies to you. If you are just now turning 65, it most likely does not. What that is for people who have been on an Advantage plan for a year to look at the new plans, because all the companies come out with new plans every year. And when I say new, they may not change them that much, but each plan is only a January 1 through December 31st contract. So they'll come out with, here's going to be our new contract for the next year. And if they change their benefits, people can switch plans and go from one to the other. If their plan worked great, didn't really change that much, they got all their doctors, they got all their drugs, they're good to go. They just roll over, and you don't have to change. It's just an opportunity to see if anything in the market is going to be better for you, and you can make a change. Before we wrap up, if you have any questions, put them in the chat. We'll certainly answer them. There's a few do's and don'ts of enrolling in Medicare. Now, this is primarily if you're going to be new to Medicare. Remember, we talked about that IRMA, that income-related monthly adjustment amount, that it's built off your income 2 years prior to when you enroll. So the first don't is don't take a retirement account distribution 2 years before you start your Part B without being aware of the financial consequences. Okay? I'm not saying don't do it. I'm saying just understand that it could affect your IRMA. And if you don't know how to approach those things, you could be paying extra for your Part B when maybe you don't have to, because there's a few things we can do. Don't delay enrolling in your Part D or Part B if it's time to enroll. Trying to save the money, it will, if you go for any extended period of time, you get that penalty. Any money you saved is going to get eaten up pretty fast. Don't automatically assume a well-known company offers you the best benefits. There may be some companies that are really strong or have really good plans when you're working, and their consumer plan may be great like that. They may not be that strong in Medicare in your area. It's not the same all over the nation. Every company is not the same in all markets. So work with a broker in your area who can help you evaluate that. Don't sign up from an unsolicited phone call. I've never talked to anyone that likes unsolicited phone calls. The reason they continue to do it is because people still answer and people still sign up. If we don't answer and we don't sign up, they'll stop doing it. But they're also not looking out for your best interest. So just don't do it. Same thing with the TV 800 number or an ad for a food card. You're going to see the ad for the food card. They are real. However, most people do not qualify for them. I'm not going to go into the details, but most people do not qualify for them. They get away with it because they are possible for some people to get. So it's not a lie, but it is very misleading. Do use a local broker that offers multiple options and who you can meet in person if you want to. Okay. We can use a lot of technology. We can do things over the phone, over Zoom. Very seldom are you ever going to even see a paper application anymore. But the ability to meet them if you wanted to really says a lot. So that means they're part of your community and they kind of understand your community a little bit better than somebody in a call center. There's no cost to use a broker. They get paid by the carriers, and we get paid a commission. That commission is regulated by CMS, and the commission is the same from all carriers. So brokers have no incentive, no financial incentive to push one carrier over another. Their goal is to get you in the best plan so that you're happy, and then you tell other people and you refer them to that broker. That's their main goal. You do not save money by doing it yourself. A lot of people think they're going to save some sort of money by not using help. This is one of those few things where you're not going to save any money. You're just going to save frustration and time, and you're going to pay exactly the same. Do make sure you're enrolling in a plan that's suitable for you. Remember, whatever your friends, family, or neighbors did may be a good plan for them. It may not be the plan for you. Everyone's is different. I'll give you a quick example. No matter what, you could live next door to your neighbor for 20 years. You both had 2 kids and they went to the same schools and they all grew up, and you think you're all the same. No, they take different drugs. They have different religious beliefs. They have different kinds of money. They're getting inheritance from someplace else. There's things you don't know. You're not all exactly the same. Make sure you understand your plan. Make sure you understand how it works. If it's an Advantage plan, make sure you have a summary of the benefits so that you can look at it, and before you go to the doctor, you know what to expect. And know what Medicare does cover and doesn't cover. Medicare in general does not cover dental. So if you have a Medicare supplement, you do not have dental insurance. If you have a Medicare Advantage plan, you might have some dental allowance. It is not provided by Medicare. It's provided by the insurance company. So most likely there's going to be a network, and there's going to be a list of doctors that you have to stay with. Some do, some don't. You got to understand your plan. All right. That is the basics of Medicare. We discussed the A, B, C's, and D's. When you can enroll, when you're eligible, when you have to enroll, that's when you no longer have creditable insurance, right? Then you need to enroll. Who you should work with, local broker, in our opinion, somebody that you can meet, although you can work over the phone or over Zoom, but just knowing somebody in your community is there that you can get a hold of is way better than an 800 number and way better than an unsolicited phone call. Please don't use those. They are bad news all around. If you have any other questions, reach out to us. There's our phone number. You can also just email us, info@billyourinsurance.com. It's pretty easy. Ask us any questions. We're happy to help. And if there's no other questions, we will log off for today. I appreciate you watching. Look out for us. We also do long-term care webinars, Social Security webinars, and lots of other things. Whenever we get questions from people and we decide that it's enough that we can get online and answer some questions, we'll do it. So thank you and have a wonderful day.